DMAC PD. Give a little more. The authors do not have any financial interest in this film. Conventionally, in DMAC surgery, corneal surgeons use centrally trifinated donor tissue, which may be called DMAC CD. In any endothelial keratoplasty, there is a constant effort by the surgeons to give more endothelial cells. That is why there are so many variations of techniques in DMAC surgery. This video tells a story about the use of peripherally triffined donor tissue for DMAC surgery, or DMAC PD. The idea is to give more while keeping the surgeon's own comfortable technique the same. We know that peripheral endothelial cell density is more than central endothelial cell density by 9 to 22% from a paper published over 35 years back. So we did a little experiment of our own using alizarin stained corneas. Which were then split into 5 parts, and then the microscopic photographs were taken. These microscopic images were analyzed using ImageJ software. This confirmed that the peripheral endothelial cell density is more and that the superior cornea has the highest endothelial cell density. Recently, using a mathematical model, Lee et al. Showed that endothelial cell density increases from center towards periphery, and eccentric triffination increases the number of transplanted endothelial cells per graft. Eccentric triffination is not practical for PK or DSEK. However, in DMAC we can use eccentric graft. We deliberately choose the superior cornea for eccentric DMAC PD graft. Donor preparation in fact starts during the in situ excision of the corneoscleral button. During surgeon preparation of the DMAC PD graft, the technique is as follows. Using trypan blue dye, the previous 2 linear scratch marks are identified. These are then made prominent and extended to the peripheral cornea with a marker pen. A 8.5 mm template mark is placed on the epithelial side with superior eccentric location. The tissue is then flipped with the endothelial side up on a Teflon block, and a 9.5 mm partial triffination is done, again with superior eccentricity. Trypan blue dye is then applied to stain the cut margins. The peripheral DM endothelium beyond the trifine mark is stripped off, and the Descemet edge is identified and gently loosened all around. The DMAC graft is then peeled starting from the superior cornea with the help of McPherson's forceps. And keeping a 3 to 4 mm hinge near the inferior part. A paracentral 3 mm stromal triffination is done, and the peeled off DM is floated back to the original position. The corneoscleral button is then flipped. And a stamp is put on the DM side after drying through the trifinated window. The cap is replaced and the tissue is flipped again with the endothelial side up. Now, an 8 mm triffination is done with superior eccentricity with extreme care so as to harvest most peripheral donor tissue. The donor graft is then completely separated from the stroma with the help of McPherson's forceps. The final DMAC PD graft is stained with trypan blue dye for a minute, and then washed with balanced salt solution. This is transferred to a petri dish containing BSS and ready for loading into an injector system. So we published our results, and the mean endothelial cell density in DMEC PD at 6 months and 1 year was significantly higher than that of a centrally refined DMEC graft. Let us see a few examples. So in the path to give a little more, it is time to convert from centrally refined DMEC graft to DMEC PD. Thank you for watching.